Hello, good evening. So I hope everyone is okay. So right now we are going to start the psychiatry class. If you find any problem, if you could not understand, just let me know. Okay. Okay. So let's start with the psychiatry. It's actually an interesting subject for MRCP. Though the questions are not so much, but very important for the exam. It's related mostly with the neurology questions and also some pharmacological questions. So we need to know the psychiatry because they will number it separately. So its numbers are matters actually in the exam. Because if you get zero in psychiatry, then it will be hamper your total passing mark. That's why we need to know. Okay, so firstly, we will go for the unexplained symptoms. Nowadays, it's called about medically unexplained symptoms, MUS. So, what are the unexplained symptoms which patient cannot explain clearly? Like, look at this somatization disorder. I think some of you can heard this uh, term, like about irritable bowel syndrome. That is one of the somatic disorder also. And there are in every system there are a lot
Sir,
functional. Hello,
sir,
yes.
your voice is not clear.
Oh, it's breaking.
Yes,
Hello, now it is clear than before.
yes.
Okay, there is some noise from. Okay, now somatization disorder, you know that there are a lot of somatization disorder. You already I think read about the systems like GIT system. You found irritable bowel syndrome, and there are some other points like fibromyalgia in the rheumatology system. So these all are the somatization disorder actually. But what we need to know specifically what is somatization disorder. Actually, in a word, we can say somatization disorder is a physical symptom. Patient have some physical problem. You must admit it that you these physical symptoms is real. Usually in PSS exam, in the final exam, you have to deal with this type of patients in counseling sessions. So at that moment, you must admit that this patient's symptom is real. This is not any kind of intentional things. They suffered a lot with this problem. So it is not intentional. You first admit it. You need to admit it. It is not intentional. Okay, it is involuntary. Another point, it is involuntary. And there is no secondary gain and no financial gain. The financial one is added by me to understand the secondary gain actually. Because in secondary gain, he has he will have some motives that he need to gain something like financial money or some promotions or something like that. So that is not present in this somatization disorder. Okay, so be clear about these points. It will help you regarding the scenarios. I will show one scenario then after this description. So look at this: not intentional, involuntary, no secondary gain, no financial gain. Okay. Now the criteria is multiple physical symptoms, at least 2 years, more than 2 years, or more than 6 months. Okay, it should be more than 6 months or more than 2 years. Both can be present in your stem. You can find in past medicine, in past test, and other on exam. All other things, there should be some duration. And the age is important. Usually, somatization disorder occurs in youngers, not like elders. Okay, less than 30 years, more. So nothing absolute actually, but you need to think in young patient, there could be some symptoms like this, two or more GI symptoms, one reproductive symptom like sexual symptoms, one neurological symptoms could be there. These are not absolute, but this could be present. And most interesting thing is diagnostic test must be normal. This is the most important part. That's why I just advise you all. to go through the first stem, like 1, 2, 3, 4, 5, 6, this stems, answer stems, and then go to the from below to upward in the question, because you should just go for the endoscopy findings, CT abdomen finding first. Then you can read from the begin start point. Okay, I will let you see with the question. All investigation are normal. CT abdomen normal, endoscopy normal, everything is normal. So what will be the positive factor? The stress and anxiety. Look, this is very important. Stress anxiety. They will not tell you in the scenario that there is a stress. There is a stress. They will tell that he is some anxious about his life. They will tell you some story. Okay, that this patient is very much upset. But directly stress will be not related with the question. Look, there are some key points you need to understand. The key points is this: if there is any kind of stress in scenario plus GIT symptom, it should be IBS at that moment. If there is irritable bowel syndrome, is there. There are some criteria of irritable bowel syndrome. You should correlate with that criteria also. But there would be some stress, like exam stress, like any kind of meetings, any kind of interviews. So the patient feeling abdominal pain, bloating, and motion, and multiple visit to the OPD, outpatient department, and also to the consultants. So multiple visit would be there, like more than 6 months or more than 2 years. Okay, so this is the key point you need to understand for irritable bowel syndrome, unlike functional symptom or not. Multiple physical symptoms means any type of physical symptoms like muscle pain, chest pain, costochondritis pain. So all of this included with the multiple physical symptoms. That is somatization disorder. Clearly, the bold point is somatization disorder. Another thing you should find is stress, irritable bowel syndrome, and there is some tender points. Look the tender points. If there is any tender point presented, if you just read the rheumatology about fibromyalgia, you can find the tender points. There should be some tender points with some stresses. I think there is noise. You can mute yourself. Okay. So that is fibromyalgia. These key points are very necessary. You read a lot during exam, but these key points will help you regarding revision. So it's very, very important. I think it will help you in future. So treatment, you should not go for any medicine. You should go for psychiatric referral and refuse. Patients are, you will give reassurance, but patient will refuse multiple times. So these are the gross treatment. And they mostly in part one, they will give you to diagnose the patient. Did you diagnose the conversion disorder, hypochondriacal, and also did you diagnose the somatization disorder clearly or not? Because ultimately you will refer this patient to psychiatry. So this is one of the description for irritable bowel syndrome, the common disorder, abdominal pain, bloating, gas. I will not describe it a lot because it is part of GI system. So in the you should read the all functional diseases in every systems. Like in GIT, this is irritable. In rheumatology, fibromyalgia, and chronic fatigue syndrome, you should read it with the psychiatry subject. Okay, I think that would be more better. Okay, irritable bowel syndrome, you should read it by your own. I will go to the another somatization disorder. I will give this note to you. Okay. Now, hypochondriacal disorder, another somatization disorder, but nowadays they will transfer this disorder to another stem, like in delusion. But so far, the question coming with the somatization disorder. So this is one of the classification of medical unexplained symptoms. So hypochondriacal disorder, it is a delusion actually, false belief. Patient have some strong belief of having cancer, but patient is okay. Cancer belief never accept the reassurance. Family history must be present there. Family history. The his parents or his mother, father, or aunt, anyone can suffer from the cancer, but he is not suffering from, he or she is not suffering from the cancer, but a strong belief over there. This is very, very important. Persistent negative belief, but you will reassure, they will not accept it. Just like this, you will go for answer hypochondriacism. This is very, very important. You will find it out in your exam mostly. This is very, very important to identify this hypochondriacal disorder, and it is so much easy. So that is a someone look. I have given one example. Someone believes that she has pancreatic cancer, just like her dead husband. Husband is dying of pancreatic cancer, and this is one of the hypochondriacal you should think of, because there is no weight loss, nothing like any kind of malnutrition and all other things that could indicate the cancer. You should read it at that step. I will share it with you. The question. Now another one, conversion disorder. Conversion disorder is the rule of exclusion actually in the scenarios, because conversion disorder they will give this question with the paralysis like a stroke and any other lesion, neurological lesion. They will give it to you like that, because this is one of the disorder you will find the patient paralyzed, like limb weakness will be there, and it is not uh, he's malingering or he's just go for the consciously that I have this loss. Is really there is real loss of motor function. Look, limb paralysis, not consciously done, not feigning the symptoms. He's not acting actually. That is the not feigning the symptoms, and loss of motor function, limb paralysis or non-dermatomus sensory loss could be there. So, in one way, you can say unresolved conflict convert into physical symptoms. There are some problem or there are some conflict in his life that convert into the physical symptoms. This is very important one. They will mostly give the paralysis there. The patient having limb paralysis suddenly, like a stroke or like any neurological issue. So this is conversion disorder, very easy, and this scenario will be a bigger one. The conversion disorder. You might say this is, there is loss, there is no jerk present, and the patient having this sensory loss also. So a lot of it, but at last the answer will be conversion disorder. I will show it to you the scenario. The history of some stress like work stress and relationship stresses, financial stresses. Stress is over there. All examination and investigations, it's sometimes found normal, sometimes they give examination like they find that there is some loss of muscle power. Could be there, but maximum time the investigation would be normal. So do not be biased with the examination part. Sometimes they will give you that examination showed unremarkable. So it could be possible in case of this psychiatric manifestation. But investigation will be normal. This is true. No organic cause, there will be no brain problem or no other spinal cord problem, and no material gain. He would not like to gain some financial benefit or some other benefit. Just he or she is in stress, and then there is limb paralysis. So that is conversion disorder. A nurse receive a patient with paralysis. Look, this is nurse is the patient. Example, she developed one-sided paralysis. This is the nurse developed one-sided paralysis suddenly on that day. Similar day, that nurse receive a patient with paralysis, then the nurse is suffering from the paralysis. She cannot remember actually what happened to her. The examination test is normal, no organic basis there. This is one of the scenario of conversion disorder. Very, very important scenario. How you can judge this patient, how you can understand that this patient is malingering or this patient have real paralysis or not. For this, there is a Hoover's test. Look, the Hoover's, Hoovers, Hoover's test, Hoover's sign should be done. This is, did you do this in your work? This is very commonly done if any patient suffering like this. Positive, it's a conversion disorder. This is a Hoover's sign. Patient, I have described it, patient placed in supine position firstly. Then there is a paretic leg and non-paretic leg. You should compress, tell the patient to compress the non-paretic leg against the resistance. Then paretic leg will give the pressure. So if there is paralysis, there would be no pressure. synergistic, no pressure if you raise the resistance. Okay, but if there is this conversion disorder, he or she will give you the pressure in opposite side. Like in paralyzed side, they will give the pressure. This is the Hoover system. You can see this in YouTube. This is very easily they have been described. So non-paralytic leg actually will give the pressure when you just move the good leg. Non-paralytic leg. If you give the resistance to the non-paralytic leg, then you will feel also the some resistance from the paralysis leg. Okay, this is some synergistic action. If you flex your if I give you some example that the patient have you just see a patient, that patient have right side paralysis, right limb paralysis. Okay, these are both limb. This is right, this is left. So if the patient is has symptoms of right side paralysis, you will give a resistance over this thigh, the left side. You will tell the patient flex the left thigh heavily, and you will put your another hand to the heel of the right paralytic leg. Then whenever you give resistance over the left side, please give pressure to my left hand. He will put a pressure on the right side. This is Hoover's test. Okay? Because if the paralysis present, she or he will not put the pressure from the paralytic leg. But you are giving this resistance to the left leg, and she is pressing you with the right to give the more resistance. So that's why there is no paralysis actually. So this is very easier and very nice test actually, Hoover's test. So if Hoover's test positive, you will answer the test as a conversion disorder. No, that is very easy. So I think these three things you understand better. Now I can go for a scenario so that you can just understand right now about this problem. Because these three is very important. You will get one question mostly. This is question out actually. You will get one from these three mostly. I'm just sharing the question. Okay, one of you can read it clearly. Anyone can join the question rapidly.
A 32-year-old woman is referred to the Department of Gastroenterology for a further opinion, having developed constant periumbilical pain radiating to both legs. Over the past 5 years, she has been seen by colleagues in neurology, cardiology, rheumatology, and endocrinology with a variety of symptoms, including fatigue, back pain, chest pain, and joint pain. Despite intensive investigations, no cause for her symptoms has been identified. What is the most likely diagnosis?
Okay. Now you can understand the investigation is normal and multiple visit over there. No? And a lot of pain, back pain, chest pain, joint pain. So there is a lot of pain. So which could be the involvement? What is the most likely diagnosis?
Somatization disorder, sir.
Yes, very nice. Somatization. I think you understand very well that this is a somatization disorder. No, it is not a hypochondriasis because there is no family history of cancer. There is no false belief. Hypochondriasis, that's why actually delusion. Conversion disorder, no, there is no paralysis, no neurological symptoms over there. So you could not think of it. Depression, there is no chance of depression here also. Low mood, loss of energy. We will read about the depression, then we will know better. Undifferentiated somatoform disorder, no, this is something you need to go for the specialist psychiatrist. So this is close. So this is somatization disorder. This can be more bigger. This scenario can be more bigger sometimes, but you need to stick on the investigations. So read it out from your lower side to upper side. That's why I'm telling you should go for the think of the investigation first rapidly. What is most likely diagnosis? Conversion, depression, hypochondriasis, somatization, and okay. So this is a psychiatric question. Now, despite intensive investigations, no cause for her symptoms. Okay. So I think investigation is normal. So any of the psychiatric symptoms, then multiple pain, this is somatization. This way you should complete your answer. Again, another question. This is not the question. This is another important one. You can read it. Anyone, Abhishek or Deepasri, you can read it.
A
A
45 year, oh, sorry, you read.
a 45-year-old electrical engineer comes to the emergency department convinced that he has severe heart disease. He has palpitations and says that he suffers a pain where his heart is under his left breast. Normally coming on when he thinks about it. Seated in his lounge, he has been investigated by the GP with an exercise tolerance test and 48-hour Holter monitor, which were entirely unremarkable. He was extensively investigated with endoscopy and CT abdomen, but that the results were entirely normal 1 year ago. He has also complained of chronic backache some 5 years earlier. He is a non-smoker who drinks 5 units of alcohol per week. Clinical examination is entirely normal. His BMI is 23. Which of the following is most likely diagnosis?
Hypochondriasis.
Hypochondria.
Yes. There is no cancer, no? But you are telling this
Severe heart
hypochondriasis. Yes.
disease. Some severe disease.
Yes. Severe, yes. That's why I'm keeping this question. Because sometimes we miss this question about thinking of there is no cancer or other things, but he has some false belief, something like that. So this is very important. You know now about hypochondriasis also. This is hypochondriasis. I think this somatization will be not missed in further. There will be more big scenario over there. You should read it from below to upward. Okay, then you can answer it very well. All right. So let's go to the next topic. And conversion disorder, I will give it with the some other question. So we know about somatization disorder. Now we have few minor things that is also important. You should just revise it very clearly, like Munchausen syndrome. Did you heard about this malingering type of questions? Factitious disorder. I think Munchausen syndrome that is known as intentional falsification, fabrication of physical psychological sign, mostly to obtain medical attention and treatment. Look, one sympathy to produce syndrome. Here, in Munchausen syndrome, this is a factitious disorder. This is intentional. Look, this is not somatization disorder. This is intentional falsification, fabrication thoughts. So these are all points very important just to obtain a medical attention and treatment. This is not financial gain. This is something benefit, some benefit from medical seeker or some sympathy he just wants. So that is Munchausen syndrome. And malingering is the financial gain. Another one is malingering, that is financial gain, secondary gain he wants to know. But in case of Munchausen syndrome, they will produce some intentional falsification news, but wants sympathy. So there are some types like Munchausen in proxy. Mother complains the child's health repeatedly. Child is normal actually, but he will tell you repeatedly that my child is sick. My child is sick. So she wants sympathy and attention. That's why. And another one, the malingering, fraudulent simulation or exaggeration of symptoms with the intention of financial gain or other gain like leave, shelter. So these are the secondary gain. So if there is any intention of secondary gain, like I need shelter, I need some financial amount, at that moment it will be malignant. So two are very similar, but there is some difference with the intention. So with the intention, you will identify this. These are very common sometimes to give in the final exam. Okay, there are some identity disorder. You
Sir,
should
can
read
you
it.
repeat Munchausen and malingering difference?
Yes, sure. Munchausen syndrome. Look, both are intentional problem. Patient will produce these problems with intentional that I want to do this. Okay, like any physical symptom, he will tell you that I have some pain repeatedly, so that I could not attend this seminar. But he or she will repeatedly tell you. So this is some intention. You want sympathy, but you will not attend the seminar. So this is like Munchausen syndrome. There is no financial gain, no other academic gain, just one sympathy from you. So this is Munchausen syndrome. And another one, Munchausen in proxy, that is mother child relation. Child is sick. My child is sick. Please see this. Repeatedly, she will come with her child, but child is normal. That is menstruation in frogs. A similar thing. Another one, malingering. Look, in malingering, this patient will get intention. Suppose I will give you one example of malingering. A patient in our hospital that is non-paying ward. That is non-paying ward. In non-paying ward, what is the benefit? There is no bill, but the benefit is that she or he will get food, sometimes also some fund. So these are the gain, secondary gain. So that's why this non-paying patient suffering from a ulcer, you are giving treatment of that ulcer, but in the same time, she or he come with the ulcer again because he made the ulcer more worse. How much danger it could be? So you can't discharge this patient as there is ulcer is very active ulcer. You are giving some medication for healing, but his intention is not to heal. He make it more abnormal intentionally. And at that moment, what he is gaining? He is gaining the food and also shelter in the hospital because he could be a beggar or could be a non-paying person. So that's why he want food, he want shelter in the hospital. He want to stay in the hospital. So that is malingering because the ulcer is not healed actually. One of these scenario is present in your past test or past medicine sometimes that the patient's foot ulcer is not healing, but repeatedly it's given, the treatment was given. It is not healing actually. The patient is making it worse for the financial gain. This is the psychiatric problem. Another that is malingering because of intention of financial gain or secondary gain. Okay, now I think you understand well with the scenario.
Yes, sir. Yes, sir.
Okay,
Thank you.
let's go with some very few clear thing. You should know this by line only. Look, dissociative identity disorder, depersonalization, difficult to know himself. Just know this thing. Derealization, difficult to know the world, know the synonyms. Dissociative disorder, loss of cognitive ability without medical explanation. Amnesia and fugue, F-U-G-E-E, fugue and amnesia. So these are two very important you need to know. Unable to recall the long period of memories. You know the short-term memories. We all know the short-term memory. Do you know the long-term memories, like in your school thing or in your previous thing? Yes, something you can tell. But in some diseases, there are certain things that happen that anterograde, retrograde amnesia will be present for the disease purpose. So these memory losses are very important to identify the disease because anterograde amnesia means the problem with the forming new memories. You cannot make a new memories with anterograde amnesia. And retrograde means you will forget the past memories. You will forget about the person you love. You will forget about the your parents. There's the retrograde amnesia also. So these are very important things. But what is fugue then? Fugue is important one. The fugue. Most of the films are dependent on this fugue. Sometimes we can see in Bollywood films and Hollywood films also there are some presentation like fugue. Look, loss of identity. You will lose the identity, wander away from the usual surrounding. When you ask about this wandering, no memory about that. This is something similar. You can find a movie of Salman Khan that is Tumko Bhulana Payenge, something like. So you can see that film and you can understand this is fugue. That is actually this. He lost his identity and he's wandered away where another family. He goes to another family, another surrounding. He does not know about any memory. That is fugue. And some question you can find in the question bank. That is fugue. Loss of identity plus wander away from the usual surroundings. When you ask about this, he has no memory actually. But later he can get the memory with the treatment or counseling. So this is very important. Fugue and amnesia. Very few term, very short-term knowledge, but it will give you a big help in the future. for answering the questions. Okay, so you should read it clearly. Another thing, look, some child and teens have some behavior disorder, that is oppositional defiant disorder. Very clumsy term, but sometimes best behaved children can have disinhibition, like sudden angry, sudden arguing, and sudden irritable they are without any disease, like any fever. There is no fever, there is no abdominal pain, there is no organic symptoms, but this child behavior is very abnormal. Persistent anger, persistent irritability, that is known as oppositional defiant disorder. Some counseling important. Actually, these patients have problem in the family. At that moment, you should call the parents and then you will counsel them. So this is, you need to know the term oppositional defiant disorder. Okay, just know the term, then you can answer. Very easy. Psychotherapy is the treatment. Sometimes this is similar like ADHD, attention deficit disorder, but in case of attention deficit disorder, this patient has some, attention deficit disorder has some anomalies, could have some congenital anomalies and some other problem. He will not complete the work. Okay, but the opposition deficient disorder is brilliant. He behave like very good. Then suddenly he can be angry and can be abnormal. So he will be a brilliant, and another one is not so brilliant. So you will just differentiate both of them with this type of information. Okay, let's go for the eating disorder. So very, very important for psychiatry, the eating disorder, anorexia nervosa, bulimia, and body dysmorphic disorder. That's why I put it in a box so that you can revise it repeatedly, because both of these three will disturb you in the scenarios. Anorexia nervosa, mostly a diagnostic criteria, there is 90% female teens, the low BMI teens actually, they have low BMI, look less than 17.5 kg per meter square or less than 85%. Intense fear of being obese. This is very important for us. They will have a fear that I am obese or not repeatedly. And there would be some amenorrhea, there would be some disturbance about weight perception. But this intense fear is very important. In scenario, you will find this thing. There's low body weight, having fear of being obese. Just these two, you will answer the emotional. Yes, there is some biochemical investigations that can be low and high. I have put it in there. You should just remember these things. Which one is lower, which one is higher. As a malnutrition, this patient may have abnormality with some hormones also. Hypokalemia, low FSH, LH, estrogen, testosterone, low T3. But which one will be raised? Raised cortisol growth hormone, raised cholesterol also, and hypercarotenemia and raised glucose. So the hormones will be low. Some hormones will be low, some hormones will be rise. You should know about that. This is physiological abnormalities. No need to think why this is happening. You just think that patient is not getting some nutrition and there is some problem. That's why it's happening. So low BMI, having hypotension, bradycardia, and also enlarged salivary gland. Salivary glands can also be enlarged. Poor prognosis, 10% patient will be died, laxative abuse. Mostly they use laxatives. They think that with the use of laxatives, they go for the, loss of food. But this laxative abuse can cause more harm like hypokalemia. Okay, these are very important things. So you can see laxative abuse in the scenario. The patient taking laxatives so much to having a low weight. Okay, so anorexia nervosa is very easy. Now bulimia nervosa, how you can differentiate both of two? In case of bulimia, you can see repeated vomiting, intentional vomiting. Patient will use his hands to go for the vomiting. So intense vomiting is important. Okay. So bulimia nervosa is a type of eating disorder characterized by episode of binge eating followed by intentional vomiting. This intentional vomiting is very important. You need to know about this. And then for the intentional vomiting, what will be found? Look, hand, knuckles, erosion, teeth. Hand knuckles will be enlarged. Hand knuckles, there will be some erosion over the teeth and also hand knuckles. There will be some injury over the hand because using this hand over the mouth repeatedly, you will get some skin problem with the hands. And also erosion of the teeth also occurs. And there are some biochemical problem like hyponatremia, hypocalcemia, hypokalemia, and alkaline phosphatase also can be listed. So this is bulimia. Very easy to understand with the scenarios. And what is body dysmorphic disorder? The more body appearance of the body problem. They will tell you that the body appearance is not in shape. This is very important information, that is not in shape, and that causes some problem. Impairment is in his social life, occupational life, and others life. So this is dissatisfaction having this body shape. Okay, so that is body dysmorphic disorder. Another one that is seasonal, like seasonal affective disorder, similar depression in winter season. Only in winter season, she or he is in depression. Mostly it's winter predominant areas they suffer like this disorder, like hyperphagia, hypersomnia, weight gain. Look, seasonal affective disorder, what is the treatment? Bright light therapy. You should know clearly about the treatment, that only the disorder where we give bright light therapy. Seasonal affective disorder. So you need to know this treatment. And in case of anorexia nervosa and bulimia, you should use cognitive behavioral therapy, CBT. CBT. These are the treatment for bulimia and anorexia nervosa. And replacement of the loss like hyponatremia, hypokalemia, you should treat it with the cognitive behavior. We will go with one scenario, and we can understand the disease. Yes, one of you can read it. Okay, Dr. Anjali, are you there? You can read it.
Yes, sir. A 17-year-old woman is reviewed in the psychiatric clinic. Her expected weight is 55 kg, and since follow-up began, her lowest weight has been 49.5 kg. She goes through episodes of binge eating and vomiting and also reports prolonged fast. Her BMI is 19 kg per meter square. She is scared of putting on weight and has missed her last 2 periods. What is a likely diagnosis?
Very important point, binge eating and vomiting.
Bulimia.
Yes, you should go for the bulimia nervosa. You should identify these key points, binge eating and vomiting. If vomiting persistent, it should be bulimia, okay? If there is any kind of weight loss, any kind of salivary gland enlargement, any other things, then you can say it's anorexia nervosa. So you can just easily identify this is the disorder of bulimia. Very nice. So bulimia nervosa. So, okay, I just want to share one thing here. Anyone can read it clearly. This is another important part.
Sir, this is not clear.
Not clear? It's
Yes.
now I can see it clearly. Anyone can see clearly?
Yes, sir, it's clear. It's clear.
To me, it's not clear. Why don't know?
I think their network problem could give you this appearance blurry. Anyone can read. You can see in the recording at that moment.
A 22-year-old male university student is brought into ED. He tells you that since waking this morning, he has been unable to stand. He explains that he cannot feel his leg below the waist bilaterally and is unable to move them. He denies any trauma to his legs, head, or back in this day preceding his presentation, and he has no pain. Additionally, he has no illicit drugs. On direct questioning, he explains that he has had challenging year in university and is likely going to have to repeat his first year as he's been unable to keep up with the exam preparation and coursework. Clinical examination reveals an otherwise healthy but tearful young man. A neurological examination reveals a normal appearance of lower limb bilaterally. There is no wasting and no tremors or fasciculations visible. The tone in both legs is equal and normal. Bilaterally, the patient cannot identify fine touch. Proprioception appears intact, but he says he cannot feel the cold of a tuning fork against his foot or vibration at any lower limb joints. Bilaterally, his lower limb reflex are normal. Power is registered at 0 on MRC power scale bilaterally. A sensory level is established at umbilicus. Anal tone is normal and blood tests are unremarkable. Bilaterally, plantar response is downward.
What is the diagnosis? Could be?
Conversion disorder.
Conversion disorder.
Yes. Yes, very nice. This is one of the, can you see this scenario is a big one? It's a big scenario. So, but answer is very easy. How you can find this very easy? If you read it from lower part. The neurological is normal. Okay, then this is not, this is not, this is not. You can just cross these three at all. If you find these all are normal. Within this, you can just cross it. These are no, only these two. As there is no something pain, there is only loss of paralysis. You can answer it within 30 seconds, I think. Within 30-second conversion disorder, you can answer. So the conversion disorder questions is like that, very big one, but answer is very within prompt situation you can answer. Okay, so that's why I'm repeatedly asking you to read it from lower zone so that you can answer within 30 seconds, so that you can get some marks in another scenarios you need to think of. Okay, so here are some stresses present or not. Look, challenging year in university. This is one kind of a stress. He has had a challenging year in university. There is some stress over there. So stress with the paralysis. So you would find very easily a conversion disorder. Okay. I think these all are clear to all of you. Now we can go for some more disorders to understand. Okay. Now we need to understand also about mechanism of prescribing medications. You are prescribing antipsychotic medications, but you need to think what you are going to do. You are going to play with the D2 receptor, you know, that dopamine receptor of the brain. So you need to know whenever you block this D2 receptor, what is happening. Okay, and what's happening to the brain. So there are some pathways for this D2 receptor. There is a mesocortical pathway, just know the name, mesocortical pathway, mesolimbic pathway, nigrostriatal pathway, tuberofundibular pathway. These are the white tracts, you know, within the brain that can connect each other to function with us. So this is very important pathways. We need to, all of these pathway having this D2 receptor. So whenever you block this D2 receptor, there will be some function. So antipsychotics mostly increase the mesocortical pathway. What is the function of mesocortical pathway? Look, mesocortical pathway is deals with emotion, motivation, execution. So dopamine decrease it. Dopamine usually decrease it. If you block the dopamine, so it will increase. So this is the side effect, negative symptoms for a patient. If you give any antipsychotic to a patient, there will be increased mesocortical pathway activity. It will be increased. The negative symptoms are the side effects of the medications, like anhedonia, loss of drive, apathy. Patient will feel sometimes there is loss of energy to do any work and loss of interest to do work, loss of drive, any kind of drive or energetic things will be lost by giving medications. But why you are prescribing this? You are prescribing to decrease the mesolimbic pathway. The mesolimbic pathway is for pleasure and reward pathway. Yeah.
A doubt, sir. So for
Yes.
Antipsychotics will cause these negative symptoms you are telling?
Yes. Negative symptoms will be exaggerated. Increase this. And antipsychotics you are putting for delusion and hallucination treatment. You will get the treatment, then you can understand. There are some side effects. Because first, I just want to introduce you with the pathways, then you can answer it. Because there are antipsychotic side effects also important for you to know. A lot of side effects with the antipsychotics, a lot of treatment you can give for the antipsychotics. Look, whenever you prescribe antipsychotics, it decreases the mesolimbic pathway. So you are giving treatment of delusion, hallucinations, and other thought disorders. So this is antipsychotics decrease the mesolimbic pathway. Actually, you can find one question scenario about that. The what antipsychotic it is true or false. In the true and false, there is it's increase mesocortical pathway or decrease mesolimbic. Without knowing this thing, you cannot answer it. Okay. Antipsychotic is not antidepressants. In case of these loss of drive, apathy, these are depression signs. So sometimes antipsychotic increase that one, but they will treat you from the delusion, hallucination, the psychotic pathways. Psychosis means some delusions, hallucinations. These things are psychosis. So you need to understand about psychosis. You need to understand about the depression. You need to understand about loss of drive and these things. Okay. Specifically, you can understand now. I am just describing it. You can see more clearly in the scenarios. So just know about this thing. Antipsychotic increase the mesocortical pathway. Antipsychotic decrease the mesolimbic pathway, which you are for prescribing for the mesolimbic pathway, delusion, hallucination, thoughts. Okay. And another effect of antipsychotics is nigrostriatal pathway over there. That's why there is some tremor, rigidity, Parkinson-like rigidity. Nigrostriatal pathway, do you know? Remember that involves mostly with the balance and rigidity. So tremor, rigidity occurs in this way. And what is activity of the tuberoinfundibulum? That is prolactin activity. Tuberoinfundibular pathway, the prolactin acts like that. So whenever you prescribe antipsychotics, it will increase the prolactin. And this prolactin will decrease the other things like libido and other things, and galactory also. So these are very important one to know. You can understand with the mechanism of action and side effects. Look, D2 receptor in heart also causing block efflux of potassium out of the cell as it is a long QT occurs. You know the long QT syndrome? Why this long QT occurs? Because there are some D2 receptor in the heart also. Whenever you prescribe antipsychotics, this will block efflux of potassium. Sometimes patient can suffer from long QT syndrome. The arrhythmia could be occurred. So these are the important pathways it acts. Okay, you can cross-check with the pharmacology. I think these are very important to understand. Look, now antipsychotics acts as a D2 receptor antagonist. This means blockers, blocking the dopaminergic transmission in the mesolimbic pathways. You are giving treatment for the mesolimbic pathways mostly. That is delusion hallucination treatment. A patient delusion hallucination department is depend on this mesolimbic pathways. So you are blocking this, and conventional antipsychotics are associated with extrapyramidal side effects. Why? Which pathway? Extrapyramidal, nigrostriatal pathway. They are affecting in the nigrostriatal pathway also. So that's why conventional antipsychotics are bad. They have a lot of side effects. All the receptors are involved. So nigrostriatal pathway also involved. That's why extrapyramidal effects. And that's why atypical antipsychotics also they are giving, because atypical antipsychotic have a specificity, more specific. They can act with other receptor also, and the extrapyramidal symptoms will be decreases. So how you can remember the antipsychotics? Haloperidol, chlorpromazine, flupentixol. So haloperidol, flupentixol, and chlorpromazine, chlorpromazine. So these are the name. Halochlorflup, you can say. D2 mesolimbic blockage more. They are working more. So conventionals are more effective with the delusion and hallucinations. That is known as psychosis. Psychosis. What do you mean by psychosis? A patient suffering from extreme of hallucinations, delusions, that is psychosis. Okay, so you need to know about the psychosis. I will give you this scale. You can understand very easily how this scale actually mood of the there is some scale of mood. So you need to know about the mood disorder with the scale. I will come. Let's go with the other three things. What are the side effects of extrapyramidal side effects like Parkinsonism, acute dystonia? There are some term of acute dystonia, torticollis oculogyric crisis. These all are happening when you prescribe an antipsychotic like haloperidol, conventional one. The conventional blocks all the receptors. D2 mesolimbic pathway, D2 the mesocortical pathway, and D2 of the tuberoinfundibular pathway, and also nigrostriatal pathway. So side effects are more with the conventional one. because four areas are affected. That's why. Okay. And then now you will give the treatment also, because you need to give these medications to reduce the delusion and hallucination and psychosis. So if you give that, you should understand about these side effects. Oculogyric crisis, torticollis over there. So diphenhydramine is used for the treatment of acute dystonia, and benztropine diazepam also can be used. These are the treatment for dystonia reactions. So severe restlessness known as akathisia, tardive dyskinesia, you will see a chorea-like movement, chorioathetoid movement, abnormal invert movement can be occurs. So how you can just a patient given haloperidol, after that patient having abnormal chewing and pouting of the jaw. What is the diagnosis? Tardive dyskinesia. Tardive dyskinesia. So haloperidol causes tardive dyskinesia. You need to know, and it is irreversible. This patient will not cured. You will just lose the power of antipsychotics. At that moment, the patient would be, treated. But chewing and pouting of jaw is the important side effects. Okay, that is tardive dyskinesia. So very, very important minor things you need to know about these types. It is very important. That's why I put it in red. You can find a lot of question over there with the conventional antipsychotics. Now, look why it's causing a lot of problem like antimuscarinic effects, increased risk of venous thromboembolism, raised prolactin causing galactorrhea, SIAD, and also IGT, impaired glucose tolerance. Tuberoinfundibular pathway. Tuberoinfundibular pathway. This pathway raised the prolactin level, galactorrhea, SIAD, and all of these. Sometimes these antipsychotics can cause neuroleptic malignant syndrome. You can understand this by high fever and muscle stiffness. I will come to the neuroleptic malignant syndrome and serotonin syndrome. These two syndromes are very important. They can reduce the seizure threshold. They can prolong QT interval, block the potassium flux. So these all side effects is a question for the psychiatry. Okay, so these you should know about antipsychotics. Phenothiazines have antiemetic antipsychotic properties, making them medication of choice for acute porphyria episodes. No need to know. Look, atypical antipsychotics, why they are very specific? Because they not only D2 block, they block also HT2A block. So these are the specific one to block, and that's why the side effects are less. So atypical agents, main advantage of atypical antipsychotics are that it work more specifically, that hydroxytryptamine, there is some serotonin receptor 5-HT2A. So these are blockage by the atypical antipsychotics. So adverse effects of atypical one is weight gain and agranulocytosis. Only two, weight gain and agranulocytosis. The typical antipsychotic is a lot side effect, but atypical one is less, weight gain and agranulocytosis. Neutropenia could be there, but hyperglycemia is another one. Look, the name of atypical antipsychotics. You can name it like Borac, B-O-R-A-Q. These are all named. Lozapine, clozapine. So olanzapine, O for olanzapine, R for risperidone, amisulfur, quetiapine. You should remember it. These names very important, because haloperidol and chlorpromazine, prochlorperazine, and flupentixol are the typical one, and atypical one are these. So you can remember with the Borac, and also you can remember as it is clozapine, olanzapine, risperidone, amisulfur, quetiapine. So there are some specific term, that is agranulocytosis and weight gain, acute neutropenia can occur. So neutropenia, which drugs causes neutropenia, you should know as a whole. That clozapine, that is one of the antipsychotics, carbimazole, that is anti-thyroid, cisplatin, that is in the oncology you will read it, and docetaxel. You have to remember these four things about acute neutropenia. Okay, the side effect. Any question can come. So these are the typical atypical antipsychotic side effects. So clozapine is very important because it causes agranulocytosis and neutropenia more and more. So you need to very aware about that. Look, how whenever you give clozapine, there should be some checklist. prior to the given, you should check WBC because neutropenia can occur in 4 to 4 month weekly. You should check 2 weekly, 4 weekly. You can remember this thing. Sometimes it can come, but I don't think it's so much necessary. Okay, now another one. The antipsychotic side effects is finished. Now the neuroleptic malignant syndrome and serotonin syndrome you need to know. The two syndrome which occurs with the medications. Very, very important syndrome. One syndrome is for the antipsychotics and another syndrome for the mostly antidepressants. So you need to read these two within this box. The common symptom are these: confusion, agitation, tachycardia, sweating, temperature high. So cat sweat temperature, you can say cat sweat temperature. Confusion, agitation, tachycardia is cat sweat temperature. So cat sweat temperature is common for both syndromes, neuroleptic malignant syndrome and serotonin syndrome. Both are the common, but which one you can diagnose by which complaint? That is muscle rigidity, muscle cramp. Very, very important with the high fever. And another one is myoclonus for serotonin syndrome, myoclonus. The term myoclonus is very important with the hyperreflexia. So these two are the main key features of the two syndromes, neuroleptic malignant syndrome and serotonin syndrome. Very, very important. Around 10 to 12 questions are there with these two syndromes. So very important to know in psychiatry. So these two syndrome, how it can happen? With the mostly antipsychotics like clozapines, haloperidol can also, and Parkinson disease drugs like levodopa and lithium's metoclopramide. All of these drugs are involved for neuroleptic malignant syndrome. A patient, suddenly you give haloperidol and patient also taking lithium. So this patient suddenly suffer from high fever with confusion and muscle rigidity is there. So if any antipsychotic given and you see muscle rigidity, muscle cramp with the high temperature, it is diagnosis neuroleptic malignant syndrome, nothing else. So neuroleptic malignant syndrome is very important to identify. The patient's creatine kinase could be higher, acute renal failure could be higher, renal failure could be there. So in which features it is similar like rhabdomyolysis, in nephrology, you see the rhabdomyolysis. It is similar like that, rhabdomyolysis. In rhabdomyolysis, there could be creatine kinase high and renal failure, acute renal failure. And the patient having exercise and a lot of work in exhaustion. So at that moment, that happens. But here, with the antipsychotics and neuroleptics causing muscle rigidity, muscle cramp, then the diagnosis is neuroleptic malignant syndrome. You will stop the drugs immediately. You will give IV fluid, and you will give DAB, dantrolene, amantadine, bromocriptine, any one of them. The serial is important. The dantrolene is the first choice, amantadine next bromocriptine. So these are the treatments for neuroleptic malignant syndrome. One of the side effects. Now for the serotonin syndrome. What is serotonin syndrome? This is also a side effect with the SSRI, that is depression drugs. We'll come to the depression. So depression drugs is SSRI, serotonin reuptake inhibitor, you can say. So serotonin reuptake inhibitor, if you prescribe only one, then with this, if you prescribe a tramadol with the patient, then patient suffer from myoclonus. So SSRI with ecstasy, MAO inhibitor, methylene blue, tramadol, any one of these, if you use, then it can happen. So you need to know these interactions, drug interactions. I read it EMTD, call, cocaine, LSD, these things. This you can use these mnemonics. A lot of drugs actually, but you need to remember the ecstasy one. You need to remember the tramadol one. These two are very important. The ecstasy and tramadol with the SSRI. If you use it, then there will be a myoclonus and hyperreflexia could be within 24 hours, patient could develop. So stop the drug, give benzodiazepine. Then patient will relax. I think you can understand with this box. This is very important box to identify your scenario. Okay. So is this clear? The neuroleptic malignant syndrome and serotonin syndrome. So neuroleptic malignant syndrome is one of the side effects which is mostly occurs with the antipsychotics, and serotonin syndrome mostly occur with the antidepressants. With the antidepressants, if you use these drugs, then patient will be a sufferer. So you need to identify these both too. This is very important slide. Now we need to know about the depression. Before depression, we need to know about the mood. Do you know what is mood? Normal mood means euthymia in the term of psychiatry. Okay, so you have two moods. One is sad, one is happy. You can be happy, you can be sad. This is physiological. What is pathological? Whenever you are more than happy, like hypomania, and more and mania, you are more and more happy. This is pathological. After that, psychosis develop. Psychosis. What do you mean by psychosis? As an internist, as an internal medicine specialist, psychosis means patient having suffering from delusion, hallucination. Delusion and hallucination are the extreme part of psychosis. So delusion and hallucination is not good. So hypomania, mania, and psychosis. Another thing, the sad part. With the sad part, you have some depression, that is mild depression. This mild depression can go to the severe major depression. Then patient can also go to the psychosis. Delusion, hallucination can occur with the depression also, and then suicide. So I think this is so much important to know about the moods scale. This is a scale, universal scale. So what is your scale? Euthymia is your scale.
Sir, your screen is not visible fully.
Yes, I can see that. Wait a minute. Why this has been gone? Yes, now it's visible. So in depression is which part? It is in the sad part. Whenever you have the mood of sadness, if you are more sad, you are going to be depressed. Like mild depression, severe depression, then psychosis, suicidal tendency. These are the scale. So how you can understand a patient is in depression or not? You need to know all of these similar things. Look, D for depressed mood, E for energy loss, P for psychomotor agitation could be there, R for recurrent idea of thought of suicide, E for insomnia, there will be excessive sleep or insomnia, S for loss, S, there is double S, that's why loss, weight loss could be there, I for interest loss, O for worthless feature, and N for no concentration. So all of these points actually important. So without mnemonics, you could not put this in your mind. You can see all of these are similar. So depression, you need to identify in the scenario. If there is any depressed or low mood, energy loss is very important. Psychomotor agitation, recurrent idea of suicide, insomnia or excessive sleep, loss of weight, interest loss, loss of interest, worthless feature, no concentration. Very important to identify every point from the scenario. This will be remembered by these mnemonics. DEPRESION. I think this is very easier if you just read it repeatedly. And this is very important because you need to understand the mixed disorders. Like with the depression, if there is any mania, then you cannot understand whether it is mixed disorder or it is only a depression. The answer is only depression or the bipolar disorder or it is mania. So you need to understand the depression first mostly. Then you can identify is from scenario. So depression mnemonics is very, very important. I will tell you to all of these things you should write with your blank paper, and you should write it. Depressed mood means low mood, E for energy loss, P for psychomotor. Remember, it is like a mathematics. If you know these all stems, you can answer that question. Otherwise, you will find that whether it is psychosis or it is a depression or it is a mania or it is hypomania, you cannot exclude that one. Okay, so very, very important. In case of depression, there would be no mania, no hypomania. Look, no substance abuse, no medical cause. These are the no. Then you can understand this is a depression. This patient is a depressive. So why no mania, hypomania in case of depression? Because it is within the scale of happiness. You are extreme happy. When you are extreme happy, there would be a mania or hypomania. That is another scale. Hypomania. Okay, that is another scale, the happiness scale. And in case of sad scale, that is depression. The sad scale is here. Okay, so very important to identify so that you can understand some disorders like dysthymia, cyclothymia. By the nature of thymia, by this thing, you now understand these are the mood disorders. Because euthymia is normal mood. Euthymia is normal mood, that is sad and happiness. Dysthymia, cyclothymia, there is some definition. Okay, there are some typical atypical depression signs. That is very important. If you know the atypical one, then you can know the typical one. Sleeps a lot, eats a lot, weight gain. This is another sign of depression. And atypical signs is very easy to remember. No, sleeps a lot, eats a lot, and weight gain. So this is a typical sign of depression. And typical all other things are you read it in depression. What is the first line depression drug? Will you give the antipsychotics here? Never.
No.
You will give antidepressants. Yes,
Antidepressant.
that is necessary for the treatment necessary to identify whether the patient is suffering from psychosis or depression. If you find there is a depression, you will answer the first line SSRI. Sertraline is the first line SSRI or citalopram. You should know about the SSRI medications. But if you give here antipsychotic, you will fail. And the answer is wrong. Okay, that's why I am just informing about you about first antipsychotic, then depression, because the depression is very important to identify. You will prescribe the first line as a SSRI, as antidepressants. These are the different drugs from psychotics, no? So that's why you need to identify them. Look, there are certain diseases that depression and this can overlap. Depression plus psychosis, both of these present. How you can understand? There will be depression feature, all the depression feature will be there with the hallucination and delusion. You can easily identify in the scenario the hallucination and delusion. Then you can say, okay, this patient have also psychosis also, not only depression. So this is a term that is psychotic depression, the mixed disorder. The patient having psychosis, the psychosis mostly a part of mania, hypomania, another entity. This is not a part of sad. This is part of happiness. As I said to you, the scale. With the happiness, what is the extreme part? The mania, hypomania. And then patient get the hallucination delusion, that is psychosis. The extreme part of happiness is psychosis, you can say. And mania, hypomania can be an extreme one, the psychosis, delusion, hallucinations. So in case of delusion, hallucination, which one you will prefer to medication? As I said, the pathway, vasolimbic pathway can produce
Atypical antipsychotic.
Yes, antipsychotics will be the treatment. Very easy. Now you can understand very easily the treatment. If you want to decrease the delusion hallucination, you should prescribe antipsychotic. Then you can give the treatment of depression. And what is the extreme part of depression? There are extreme part of depression also, suicide. At that moment, you should give the antidepressants. With this method, you will answer the question answer. Okay. So if you find that depression will kill the patient with suicidal tendency, then you should prescribe first line antidepressants. If you find the patient having delusion, hallucination, and patient having more psychosis in the scenario, then the answer will be antipsychotics. Now you can answer all the question if you go through the question bank. Let's go for further. So what is the management of depression disorder? Antidepressants, and also stop the depressing drugs like steroids, alcohol. Antidepressant is the treatment of depression. Okay, so you need to know, and there are some other therapies you can give, not so much important to us, for us. Now we will go for the hypomania and mania. Look at the hypomania, mania. Presence of psychotic symptoms differentiates mania from hypomania. That means hypomania is the milder one. The mild, you know, the mild depression, here the mild happiness disorder. So hypomania is the milder one, mania is the higher one, because presence of psychotic symptoms differentiates mania from the hypomania. So in case of mania, you will find delusion and hallucinations. So maniac patient having psychotic symptoms more and more. There could be some symptom like hypomania, but more and more psychotic symptoms over there. So delusion, hallucinations, wherever you find, you will prescribe antipsychotics. Now, delusion of grandeur. There are some specific delusion for the mania, that is delusion of grandeur. Grandiose. Patient think that he is big, he is the leader. So this is a delusion sometimes. And auditory hallucinations, which are the most specific auditory hallucination? Patient hears some other voices. This is auditory hallucination, no? So these are the psychotic symptoms. Now you know. What are the mania, hypomania common symptoms? Look, more happiness, mood is elevated. This is pathological scale of happiness. You are happy, you are good, but you are maniac, not good. No, the hypomania, mania, we won't prefer. So patient is mood is very elevated, sometimes irritable, very high speech and flight of ideas are more, but poor attention to your talk. Behavior will be abnormal. There will be loss of inhibitions. Sometimes you would do such work that is not good. There is loss of inhibition, insomnia, increased appetite. So these are the mania and hypomania symptoms. And which is the worst part of mania, hypomania? That is delusion, hallucination. These are the worst part. Extreme part of delusion. Okay, extreme part of mania, hypomania. And it is from which cycle? You know, the happiness cycle, extreme happiness cycle. So, okay. Now we can go to the next bipolar disorder. Now you can understand easily. This term now you can understand if I draw the scale. Again, I am drawing this scale. Look at this. The scale is sad. Where is the sad? Happy. Sad means you are mildly depressed. Then you are severe depressed. Then you are in suicide tendency. Happiness means here you are more than happier. That is, you are hypomania. You are suffering of hypomania. That is similar to the mild. Sorry. I'm just going for, you are in hypomania. Now more extreme part is mania. What is the mania part? That is psychosis. No, psychosis. Delusion and hallucinations. Then suicide can occur in both sides. So most common side. Now you can see the scale, the sad and happiness, mild depression, that is hypomania in this part, and severe depression, then maniac, psychosis. So these are the scale. Look now about the definition. Major depression more than 2 weeks. Where is the major depression? That is severe depression. I can say very easily that is severe depression. This is the major depression. With this thing, if there is mania for more than 1 week, I means that more severe, sad and happy. So both of these two. Severe depression, major depression and mania, if present Simultaneously, this is bipolar 1. Bipolar disorder 1. Another thing, look, 1 major depression, 1 hypomania, no manic episodes. That is the cycle. That is the pinkish one, the severe one with the hypomania. This is another scale, is bipolar 2. Now you can understand how they scaling this bipolar 2. The severe major depression with the hypomania, that is mild severe happiness. So mild problem with the hypomania, that is bipolar 2. Cyclothymia, look, cyclical mood disorder, mild depression and mild hypomania. So mild depression, mild hypomania, that is hypomania, it is for 2 years. So cyclothymia is in this area. So mild and mild, both mild one is the cyclothymia, no? Both mild one is cyclothymia. So that is mild depression plus hypomania. Both are in mild scale. So if this happened for 2 years, this is cyclothymia. Cyclically, patient suffering from sometimes in mild depression, sometimes in hypomania, sometimes in mild depression, again in hypomania. So if this cycling occurs, this is cyclothymia term. And dysthymia, only chronic mild depression for 2 years, no mania and hypomania. Only dysthymia means depression problem, mild depression for 2 years. There is no mania, hypomania. That means happiness disorder cycle is absent there. So that is dysthymia. So I think now it is clear this cycle of scaling of this disorder. So you can understand very easily. You need to identify whether there is major depression present or not. Like 5 features should be present from the D, E, P, R, E, S, I, O, M. These are the mnemonics. If you find 5 or more, then it is major depression from the scenario. So you need to find it out whether there in that scenario there is depression scale present or not, 5 or more. And 1 hypomanic means in hypomania, what are the symptoms of hypomania? Flight of ideas, irritability, elevated mood, abnormal behavior. These are hypomania. And maniac means no delusion hallucinations. No manic episodes means no psychosis. No delusion hallucination on the scenario. So this is bipolar 2. I think very easy now. You should just learn the cycle, learn the scale, the happiness, sadness, then you will read it. Then it will be easier to identify from the scenario. Okay, so these are the scale for the hypomania, mania, and also the psychosis. And when you will put the antidepressants and antipsychotics. Okay, these are the very important thing for today. And now you will also read it from the pharmacology, the antidepressants. What are the antidepressants? You know, that is tricyclic antidepressants sometimes present. TCA, there are some side effects of that antidepressants, tricyclic antidepressants, drowsiness, dry mouth, blurred vision. You should read about that. Next is what are the side effects of that? It is in the pharmacology mostly. Tricyclic overdose in the toxicology you will read. So you can read from here. And another thing, the SSRI. You should read from the SSRI from these notes. These are very important notes. Selective serotonin reuptake inhibitor. This is the first line actually for depression. SSRI, not tricyclic antidepressant. Because tricyclic antidepressant has a lot of side effects. But SSRI have minimum side effects. Like there is citalopram, sertraline, citalopram. These are the drugs of antidepressants. Okay, SSRIs. So sometimes there are some specific one, like you can use sertraline in case of MI, myocardial infarction with the depression. You can use fluoxetine as a choice sometimes. So you will read it specifically. It will help you. There are some side effects. You should not discontinue SSRI suddenly if a patient taking it. You should gradually withdraw it. Otherwise, withdrawal symptoms occurs. Okay. So these are the important things for pharmacology. And there are some interactions can occur with the SSRI. If you prescribe SSRI for a patient, you should not prescribe with the NSAIDs, warfarin, heparin, aspirin, these things can causes interactions and more side effects can occur. Okay. Now, there are some symptoms, discontinuation symptom. If you discontinue the SSRI suddenly, then patient can have vivid dreams, can have pain sensation in the heads. These two are very important discontinuation symptom of SSRI. SSRI should not withdraw suddenly. It can gradually, like steroid. If you use a steroid for more than 3 months, 7.5 milligram, then you should gradually withdraw it. Similar like SSRI, if you use antidepressant like this, you should gradually decrease it. Then discontinuation symptoms can be prevented. So just read this one, which one is preferable for which one, and what are the indication of SSRI. I have given you the mnemonics. These are the first line treatment of SSRI. Depression, general anxiety disorder, binge eating disorder, gambling disorder, panic disorder, premature ejaculation disorder, OCD disorder, PTSD. All of these things treatment are SSRI, first line. So you need to know these disorders. We will read in the next class the personality disorder and general anxiety disorder, sleep disorder. These are very interesting. I will give you details in the next class about that. So SSRI, how I can remember? I remember the CSF para term, citalopram, sertraline, fluoxetine, paroxetine, CSF para. And what are the indication? DG, BG, mature obsessed trauma. So these are the diseases we can use first line treatment for SSRI. So I think that's for all for today. I will give you some scenarios of depression and bipolar in the next class, because today you will not get that. If you read it clearly, then you can understand that. Okay. Then I will start with the questions in the next class. Then we will go for the personality disorder, like schizoid disorder, many other personality disorder are there. We need to know. Okay, I think enough for today.
Sir, can you share the notes?
Yes, I will share it to the authority. They will provide you the notes. I think that's all for today.